So this afternoon, what we want to cover at pretty high level, I have to say, because of the time, is we just want to look very briefly at some comparisons of your system and ours, to look at a formal definition of patient-centered care, and to introduce you to some of the evidence on the relationship between patient-centered care and clinical outcome. And then, most of all, I will hand over to Helen, and what we really want to do is take you through the contribution of design and design thinking to healthcare, how experience-based design works, and to look at an example of it in practice. So, here's some figures which I hope you can see quite clearly, which are from the Commonwealth Fund. These figures are based on public surveys in 11 countries of how the public rate their healthcare system, and I've flagged up Canada and the UK. So the question that was asked was, does your system need minor changes, fundamental changes, or does it need rebuilding completely? And what you can see is that the level of support and appreciation of the NHS in England is extremely high as compared with other countries, and indeed as compared with your systems here. So there is immense public loyalty to the NHS in the UK, and has been for, well, since the war. So, but actually, if we look at some other Commonwealth Fund data on how different systems perform, and this is data for 7 countries, and again I've flagged up Canada and the UK. So going down the vertical axis, you can see that these are indicators of based on measures of quality, so measures of effective care, coordinated care, patient-centered care, and so on, and including at the bottom measures of efficiency and equity. And it's a traffic light system, and what you can see is that the UK performs better on most dimensions than your system. And I show you this not to be smug, because I think there's quite a lot of problems with some of these data. They are very high level. But where we do very poorly, 7th out of 7 is on patient-centered care. So we seem to be getting quite a lot right, but not that. Here, you are 5th out of 7 in this ranking for patient-centered care, but you do very well indeed on long, healthy and productive lives, which is interesting, and you might want to speculate on the reasons for these data. So just to give you an idea of, we do come from different systems, but we all have problems with the way that patients experience care. So what is patient-centered care? This is the recently published, this year in fact, standard definition that is now been adopted by the NHS in England for patient experience. And it's based on the evidence from good research, good both qualitative and quantitative research with patients going back to the 1980s, so starting off with the work of the Picker Institute in the States in the 1980s. This is very close to the definition that's been adopted by the Institute of Medicine in Crossing the Quality Chasm. And it's useful, I think, and it's useful to reflect on the fact that patients' experience is multidimensional. It encompasses very many different things, and it's always impossible to remember long lists like this, but I think it's useful to think about the fact that on this list you have both transactions, so the what is happening in healthcare. So if you look at something like coordination and integration of care, or transitions and community, or access, these are all transactional aspects of patients' experience. And then there's the relational. So there's a lot in here which is about how people are treated. So patient's experience is, in other words, the summation of both what happens and how it happens, and both are important to patients. And in some cases, some elements are more important to some patients than to others, which is where the meat of it lies. So what's the relationship between experience and outcomes? Now, we've known for some time, this research study was published in the mid-90s. We know that the quality of care in hospital environments is affected by more than just the technical quality of the medical care. So we know, since we've known for a long time, that the quality of interpersonal relationships makes a difference to patient outcomes. And we've also known for some time that the quality of the amenities and of the environment impacts on patients and their well-being. We also very recently are beginning to see the results of research into the relationship between what patients say about their experience and other dimensions of performance. So we've seen some published work that suggests that high-performing organizations that do well on patient experience also do well on clinical quality. What these data don't tell you about is how the association works. Is it that the clinical quality comes first and the patient experience second? Patient experience comes first and clinical quality second? Or is it that they're both independently driven by other factors? But there is a small but growing body of evidence that shows in some detail, that begins to unpick the relationship between aspects of patients' experience and clinical quality. So evidence from different settings, evidence from the relationship between patient-centered care that is intentionally centered on patients and outcomes in ITU, in surgery, in cardiology. Good evidence on the relationship between effective communication with patients and the impact that has on the way that patients use drugs, whether or not they are good at managing their symptoms, whether they come for help when they need it, and some good evidence that anxiety and fear, emotional distress, delay healing, and therefore, in some cases, delay discharge from hospital. And the other area where there is some research, and as I say, this is a small but growing body of evidence, because actually there hasn't been, until relatively recently, a lot of research interest in these relationships. But there is also some evidence on the relationship between patient-centered care and some aspects of patient safety, including mortality, and including hospital-acquired infections, and you can see the list there. So the point of this section of the talk really is to suggest to you that being interested in patients' experience is not a question of it being an add-on or something that is pink and fluffy and nice to do, but we can't really afford it. It's actually integrally related to quality. So just a couple more words about design and healthcare. Design thinking first came into healthcare relatively recently, in the last 5 years, and probably the seminal book on this and the seminal papers have been written by Paul Bate and Glenn Robert, both of whom have worked a great deal with both the Institute and with us at the King's Fund. In the UK, experience-based design has taken off. It's taken off particularly in hospitals. So we've seen it applied in different organisations, different acute trusts. We've also seen it applied in different settings, so in accident and emergency departments, in cancer services, in intensive care, in respiratory services. We've also now just seen it beginning to be applied in end-of-life care. and also by commissioners. So there's now a pilot project looking at commissioning using experience-based design. And it has travelled internationally. I think it's very exciting, the level of interest that there seems to be in it here in Canada. It's also moved to Australia. Particularly Glenn and Paul have taken it there and done a lot of work with people in New South Wales in accident and emergency services, but also in mental health services and also in New Zealand. So this thing is beginning to spread, and the characteristics of it are that it's participatory, and we'll talk more about that. And where design thinking comes in is that the interest is in the interaction between a product and a service. So Apple are not where they, are where they are today because of the level of interest that Apple have paid to the interface between their products and the user, essentially. And so it's that kind of thinking that is now applied in healthcare. Design thinking is typically very pragmatic, not very theoretical, and it's particularly interested in prototyping and modelling. So if you work with designers, typically what they do is they test solutions out all the time, and they test them until they have designed a prototype that works, and then they spread that. So that's really the kind of thinking that people have learned to apply in healthcare services. So with that, I'll hand over to Helen, who will take you through the application of it.